Thank you everybody for joining us and welcome to this evening's webinar, Type 2 Diabetes Management and Support. My name is Jasmine, your RACGP representative for this evening, and we are joined by our presenters, Annabelle Thurlow and Angela Blair. Before we get started, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past, present and emerging. I would also like to acknowledge any Torres Strait Islander and Aboriginal colleagues that have joined us online this evening. So let me introduce to you our presenters for this evening. Angela Blair is a credentialed diabetes educator for more than 40 years, and her passion continues to be supporting people living with diabetes. She is responsible for the development, delivery, and review of many programs for children, adolescents, and adults living with all types of diabetes. This has included training for health professionals both face-to-face and in the e-learning format. She is currently the Senior Clinical Advisor for the Get Healthy service while continuing to work a CDE. Annabelle Thurlow is a diabetes educator for 35 years and a diabetes nurse practitioner for 16 years and is very, very passionate about diabetes. Her focus is on educating healthcare professionals and people living with diabetes with a goal to make every person she sees feel more positive about self-managing their diabetes on a day-to-day basis. Some of her key achievements include piloting a diabetes telehealth program, looking after patients from as far afield as Alice Springs to Broken Hill, Pakistan and Nepal, and Insulin Pumps Australia as a service dedicated to management of diabetes with insulin pumps and continuous monitors, supporting people around Australia living with diabetes. By the end of this session, you should be able to discuss evidence that supports healthy eating, physical activity, and health coaching for people at risk and living with type 2 diabetes, including older adults. Outline the importance of healthy eating and active living behaviours for people prescribed GLP-1 medication. You should be able to describe how the Get Healthy service can support people at risk and living with type 2 diabetes and how to refer patients, and understand how the Get Healthy service can support people at risk and living with type 2 diabetes and how to refer patients. And let me hand over to Angela.
Good evening, everyone, and thank you for joining us. I thought I'd start with just a few little points about diabetes. And I'm sure most of you may know this, but there's roughly one person diagnosed with diabetes every 5 minutes in Australia, and it's about 330 roughly people diagnosed every day. We use the National Diabetes Services Scheme statistics to actually demonstrate how many people are living with diabetes at the moment. And while it says here, at the moment, there's about just over 1.5 million in total, of which about 1.23 million are living with type 2 diabetes. So it's a large group of people. In New South Wales, that number is around 20% of that figure. So New South Wales has quite a large, it's the second largest state or territory for type 2 diabetes. On the slide, though, it talks about a few factors that contribute to that. And one is that 95% of Australians actually say that they have an inadequate fruit and vegetable consumption. And I think that's something to keep in mind. And as well, look at the 1 in 2 Australians who have either no or low exercise levels, because both of these things, nutrition and exercise, both contribute to the development of type 2 diabetes. So we know where we're sitting. When we look at these figures, though, of diabetes in Australia, we know that for the roughly 1.5 million people living with it, there's about 500,000 people we know that are out there that are at risk or undiagnosed or may have pre-diabetes. So it's quite a large group in our population that we should consider. And that's why we're talking about it tonight. So thank you. So the first section we're going to cover is supporting people with lifestyle matters. And so I think we can all agree that on the importance of lifestyle in achieving better health outcomes for our patients. I mean, that goes without saying. There's so much research out there that underpins just how valuable it is. But we know that even if the medication is there, it's the lifestyle factors that go hand in hand with that actually help manage diabetes. and improve those blood glucose levels, which then in turn helps reduce the risk of diabetes-related complications, as well as delay the need for increasing amounts of or types of medication, including insulin, to manage type 2 diabetes. Lifestyle changes positively also improve blood pressure, cholesterol, and weight. So they're key drivers for cardiovascular risk. And we know that cardiovascular disease is one of the leading causes of death for people with type 2 diabetes. So lifestyle is a very important component of how we manage diabetes. There's so much evidence that we could provide that supports early intervention through lifestyle in delaying or preventing the onset of type 2 diabetes in our at-risk community, especially those with prediabetes. Making healthier food choices and increasing physical activity can reduce the onset of type 2 diabetes by up to 47%. So find them early and get them started with lifestyle changes is important. The Diabetes Prevention Program, if you've heard of it, it's called DPP for short, started in 1996 in the UK, and it's the largest ongoing trial of people living with diabetes and looking at outcome measures. What that's demonstrated is that lifestyle changes outperform medication in preventing type 2 diabetes. So that's just one of the great pieces of information that's flowed on from that. And unfortunately, diet is the single largest modifiable risk factor. So, and that's globally. It's not just in Australia, it's around the world. So we believe that by using motivational interviewing, brief interventions, and referring on to allied health services such as dietitians, diabetes educators, exercise physiologists, psychologists, a range of health professionals, are tools that you can use in everyday practice to support your at-risk patients in modifying their risk factors for either developing type 2 diabetes or delaying the onset of it, or if they've got diabetes, to better manage it. And I think that's really important. So the key lifestyle factors are, I'm not going to talk too much about these. Healthy eating goes without saying. We like to call it healthier eating now. A lot of the people we see will actually say, oh, but I already eat healthy. So we've tried to change the narrative a little bit to say, well, we want you to eat healthier so we can get better health outcomes. Physical activity goes hand in hand. As you heard, I've been a diabetes educator a long time, seen lots of people, and really often it's the physical activity that has the greatest impact for managing diabetes. And that includes very much strength-based exercise. It's so important for so many reasons, and I'll talk about that in a couple more slides. Healthy weight alongside mental health well-being, including stress management, but that also includes sleep, it includes mood, emotional well-being. So there's so many things to unpack in that one little box. And then the last one, while it says alcohol reduction and cessation in pregnancy, it's also about smoking, recreational drugs, vaping, and all the things that go along with that. So when we look at lifestyle areas that we can focus on, it's really looking at those as a group. But the one that's not listed there that I'd really like to point out is one that's a newer one that we're really starting to work with people in the diabetes space, is sleep. And sleep is that thing that goes hand in hand with type 2 diabetes. It's one of those chicken and egg situations. Does the sleep apnea come first, or does the type 2 diabetes come first? And often it's one or the other, and then it's a cycle. So when people are reporting poor sleep habits, it's worth investigating. We know that some people turn up and their diabetes is quite well managed, but they're having their fasting blood glucose levels are still quite high. That can be because they're having that disrupted sleep overnight. So just put that on your target going forward. So I thought we'd quickly cover nutrition at a glance, knowing that I am not an accredited practicing dietitian, but as a diabetes educator, we focus very holistic when we're actually talking to people. So I thought I'd throw in some of the things that I think about as a diabetes educator. We know that there are many diet options now. If you go on social media, if you look at the Apple News, for example, or any of the news that's out there, they're either talking about GLP-1s or they're talking about which diet does the best job. I wish they'd talk more about which exercise does the best job as well. So there's many options out there and people are going to come to you and they will have a preference, and our job is to work with that preference. But I'm going to give you some very general guidelines that we use as educators, and that is focus on whole foods, foods that are high in fiber. Drink more water, because if you eating the fiber, you need the water to make it all work. Choose low glycemic index carbs. You know, a great example is just switching from white rice to basmati rice is a low GI and stops those post-meal spikes, as does limiting those added sugars and refined carbs. We also want to look at people's general health, and that is reducing their saturated fats and including those healthy fats in there. You know, and they can keep people feeling fuller over the day as well. Moderate alcohol intake, or if pregnant, none. And, you know, that can sometimes be a bit of a challenge, but, you know, it's part of, still have to have some enjoyment in life, I guess. That's what many of the people I've seen have told me. So my particular practical tips that I tend to use is if I'm seeing someone that's newly diagnosed with type 2 diabetes, I like to focus on that simple swaps to start with. And that might be eating 3 meals a day as a start. It might be having breakfast where they might not have. It might be swapping their sugary soft drinks or their fruit juice to water, for example. So little things like that. Swaps can be a good place to start. They're a first good goal to start with. If they can achieve those simple swaps, it usually helps them move on to some of the more nutrition goals that they need to set. Will mention that there's a program at this point called Type 2 and Me that's on the NDSS the National Diabetes Services Scheme website. And we actually encourage our people that are newly diagnosed with type 2 diabetes when they're first registered on the NDSS to do this program. It's full of videos and just simple steps for them to take to start managing their diabetes. And in that program, we talk about the swaps, but we also talk about the plate method. And that is one really easy place to start. Look at your plate, half veggies, whether it's breakfast, lunch or dinner, a quarter protein and a quarter carbs. And it's a really good starting point for many people. Menu planning, reading foods labels is the next step. And often it's a great idea to refer them to the dietitian for just that personalized advice if they are really unsure of what to eat and the quantities that they need to have. The dietitian is best placed to give that more specific information. Next one, faster. Physical activity, this is my favorite thing to talk about. Again, we're going to talk very generally, but the Australian guidelines for, you know, that adult age range is for 150 minutes of moderate aerobic exercise per week. And how people can achieve that is walking, swimming, whatever they choose to do. It's important to include that resistance training or weight-bearing training because that builds muscles. We need it to be at least 2 to 3 times a week, depending on that person's ability, because it does improve their insulin sensitivity. So it's the one thing that can help really bring down those blood glucose levels. And that can be as simple as getting some tins of salmon, for example, some water bottles filled with sand, right through to going to do Pilates at a gym. And there's lots more options now out there for people to actually do some exercise programs. My practical tips for when I see someone is to start small. You know, getting them to do 10 minutes walk after meals can help with those post-meal spikes, but also it gets them started and it's not a huge commitment. 10 minutes is something that's achievable. Back in the day, we used to want them to do that whole 30 minutes. And for some people starting out on an exercise program, it's just not achievable. I try and tailor it to the person and what they want to do. Not everyone wants to walk. They might not live in the right area. Other people love swimming and they love, swimming might be their choice. A referral to an exercise physiologist or a physiotherapist can actually help as well if they want that more tailored approach, if they're not really sure what to do. If they can't do that, there's New South Wales Health has a website called Healthy Eating and Active Living. And on that website are some exercise options for people to start, some little programs that they can start out with using, and some other information that goes along with that to get them going. I like to also encourage them. I don't do it for them, but I like them to go out and find out what's in their local area that they can actually join. Sometimes just joining the local Pilates group or yoga group, or there's, a beach walking group, can actually not only give them that exercise, but it can actually give them the social supports that they need with a community of like-minded people. So I think that's really important as well. The next, of course, is achieving a healthy weight. Weight's become a bit of a contentious topic at the moment, because there's a lot of work being done around weight stigma and what those words mean that go along with weight. What we do know is that a 5 to 10% weight reduction can significantly improve outcomes. We know that, and it certainly can reduce the risk of going on to develop type 2 diabetes or altogether. We know that to achieve that, it has to be sustainable and realistic changes. Some people I'm using the word diet in inverted commas, but they find an eating plan that actually they can't continue to achieve. They get hungry, they can't find the foods, it's costly. There's a whole lot of issues around now getting the right eating plan for that particular person. And I think it's really important that we make it as simple as we can for people. We focus on reducing abdominal fat, and that may not need them to be weighed as much. Certainly a tape measure around the waist will tell you if that's being achieved, but so will their belt and their whatever waistband they're using can actually tell them, because of that stigma. I think we're really learning how to have a better conversation around weight with our patients. What I do, this is my particular way of doing it, I try and not use words like obesity, overweight, things like that. I tend to talk about healthy weight. What's a healthy weight you'd like to reach? Trying to encourage them to look at a number, that's more like, I just want to be smaller, rather than saying I want to lose 10, 20, 30 kilos. That's putting a number on it, and then it's trying to achieve that number. Always ask permission if I'm going to weigh someone, and they've got the right to say, no, I don't want to be weighed. And then we look for some other way of getting that information. I've tried to focus on their health, not their appearance. I think I don't have to explain that one. I think social media has sorted that one out for us. And I explore what they want by just asking those open-ended questions like, what would you like to do to reach a healthy weight, and things like that. Try and listen without interrupting. And, it's really important to acknowledge their challenges, but also acknowledge, how they're progressing. Sometimes it's really hard where they're doing all the right things, but their weight loss is a little bit slow, and they can become quite discouraged. And I think it's really important to encourage and say, look, you haven't, your weight's stable, rather than saying, oh, well, you haven't lost anything, because it keeps them motivated, keeps them going. And so you're validating, as it's written there, validating their experiences. But my whole thing is focusing on small steps. I learned that very on when I started as a diabetes educator, when it was, relatively a new thing, that, people are people, and we've just got to work with them. But I think you'll all agree, talking about weight's a bit of a tricky topic these days. Mental health and well-being, I think, we can talk about this in a number of ways. And, I've I've added a few things around that. I think it's important to understand living with diabetes, it's a chronic condition and it's really quite relentless. If you're monitoring, whether it's with CGM or a glucose monitor, you have to do it all the time. And people are always looking at those numbers and having a sense of, I've done okay or I haven't done very well. And it's their own judgment that can sometimes interfere with how they're actually managing their diabetes and how they feel about their diabetes. They're more likely to become anxious, become depressed, but more often than not, it leads to diabetes distress, which is they get to the point where they just go, oh, no matter what I do, it's not enough. And we have to reverse that thinking and try and say, well, let's start again, but let's look at little things that we can change and move on. I think it's really important to, stress impacts glucose levels. And the more stressed over the day a person is, it can actually lead to above target glucose levels. And that's something that we need to kind of be mindful of. My ways of looking at it is strategies, and I love that I've written down mindfulness, meditation, and relaxation techniques. I don't actually quite use those words. But we try and ensure that people think that there has to be fun in their day, that they're not just thinking about their diabetes all the time. And it's about finding things that give them a sense of feeling good about life, and trying to incorporate some of their diabetes management into that. So if they're going out for dinner, they go out for dinner and they still enjoy it, but they can still manage their diabetes while doing that. The same as connecting them in with support groups, people around them with like thinking. Often people go to their local bowling club and they find that because of the age of most of the bowlers, they're not the only ones with diabetes, and it becomes almost a support group within a bowling group. I don't know what to call it. But there's always the option to refer them to specialist mental health practitioners, so the local psychologist, social worker, for example. But part of that is that then the conversations around smoking and alcohol, because they can be linked into those, how people feel about their mental health as well, and maybe using those as part of how they deal with their mental health. But it's important to know that smoking increases insulin resistance, therefore, and cardiovascular risk and diabetes-related complications. So it's, one of the things that we have to find the right way of encouraging that cessation of smoking and vaping as well. And the same with alcohol. And, I guess one of the important things is we try not to restrict alcohol for most people unless there's a reason to, but we know that alcohol consumption has an impact on weight, on blood pressure, on insulin resistance. And, I can't tell you how many people have said to me, but they tell me that a glass of red wine a day is good for my heart. And, you have to go, but a bottle isn't. So, we have to be mindful of how we have these conversations. So my method of supporting someone with lifestyle changes is to help them set their own SMART goals. It's really important to focus on what they want to change rather than what you think they want to change. It's really easy to go in and say, you need to do this, this, and this, and that will make your diabetes manageable. But they might not be what is their agenda and what they want to do. And I think it's really important that we can, have that conversation with them and get them, on that path of what they want to change. And once they change one or two things, they often want to change more. So it becomes, if I can do that, then I can do a bit more. I can do a bit of this. Not everyone, when they're newly diagnosed with type 2, want to monitor their blood glucose levels. And so there's other ways that you can get them to that point down the track. And probably they don't need to at first. It's down the track they need to. We use a lot of motivational interviewing as educators. It's something that we like to think we're good at, because we want, as I said, we want the person themselves to decide what they want to change. But it's really important as part of that is to explore what their barriers are, because they can learn from their barriers. They can actually use those to actually do better with their goals. If we just ignore them, they will crop up and the person often then stops. And we don't want that. We want them to know that it's not just going to be, oh, I've got a new goal and I'm going to achieve it. I want everyone to stop for a minute and think about New Year's this year. How many people made a health, you know, I'm going to do this in this year, like a commitment for 2025, and already didn't. I have a friend that tells me every Saturday she eats whatever she wants because on Monday she's going to start eating healthy, but by Tuesday she's not. And that's where goals have to be specific, measurable, achievable. You know, the worst goal people can have is I'm going to lose 20 kilos, because what are the steps? What are you going to do and how are you going to achieve that? So follow up, look at progress. Remember, you've got lots of health professionals that can be part of the team. And that includes programs like Type 2 and Me. It can include programs like Healthy Eating and Active Living, as well as the Get Healthy service. And I think these are really good tools that you can use to support you with the patients that you see that need that support. So just to finish off this section, I thought we'd have a quick case study. And this is someone that we've seen together. Mary's 48, female, identifies as female. She has a BMI of 32, elevated fasting glucose and a HbA1c of 6.3%. She lives alone and has a relatively sedentary lifestyle because of her job, and then she's tired when she gets home. Her OSD risk indicates a high risk of developing type 2 diabetes, and that's mainly due to her family history and her cultural background. And she's considered as having pre-diabetes at this stage. And so the intervention that we started with was nutrition and physical activity plan. And she made some goals around what she wanted to change in both of those. And she was referred to the Get Healthy service to do that. So Mary attended 10 fortnightly coaching sessions over about a 4 to 5 month period. After 6 months, her HbA1c had improved. It was down to 5.6. She'd experienced an 8% weight loss, and that was mainly due to her increased physical activity levels. She did tweak what she was eating, but it was more around her physical activity. And the good news was that Mary was less isolated as well, because she joined a local yoga and Pilates program that she then met some women in her age bracket and started having coffee with them and things like that. So she had a really good outcome. So I'm going to ask Annabelle to join me now, and we're going to just got a few questions I thought we'd have a bit of a chat about. So this is Annabelle. So Annabelle, you know, when we think about, you know, and we've seen lots of people like Mary, but what would be your rationale for referring her to the Get Healthy service?
So good evening, everybody. The rationale would be that Mary has been diagnosed with pre-diabetes. The HbA1c indicates that. And actually she's 6.5 plus would be type 2 diabetes. So she's at the higher end of the scale there. Her BMI indicates that she is actually considered obese, and she admits to having a fairly sedentary lifestyle and a family history. So her risk for developing type 2 is relatively high. So she was quite excited to be referred to this program, and she committed to the 10 sessions, which was excellent. Something that probably encouraged her to attend it was that it's free. And she was willing to attend, and she did very well on it, because she managed to reduce her HbA1c down to 5.8, still considered to be pre-diabetes, but much better than the previous HbA1c. The weight loss was quite significant, as Angela mentioned, at 5 to 10% weight loss reduces the risk of type 2 diabetes, reduces cardiovascular risk factors, reduces her risk of even about 14 different types of cancer, reduces the weight on her knees and hips. So overall, it was very significant. So I think the rationale is really to get her motivated and reduce many of her lifestyle risks. She then when she was spoken to, we also mentioned to her, we asked her about her alcohol intake. Another thing that, and she indicated that she actually didn't drink a great deal of alcohol, but there was something else that we brought up with her, and that was that she's 48 years of age, and we asked her whether she could be actually perimenopausal, to which she sort of said yes, but when we discussed it further, she was actually displaying signs of perimenopause, which we know increases insulin resistance, and it can have cause sleep disturbance, and and mood, which then impacts on her desire to exercise and maintain, a weight loss program. She was really happy to talk to us about this, and in fact, she was delighted to think that somebody was interested in the fact that she may have menopause and be going into perimenopause, and that she had no idea that it could impact on her risk of diabetes. So that was news to her, and that was a motivator for her to also attend that program.
Yeah, that's really good. I think, when we think about people like Mary, they're everyday people just out there, and knowing her risk is really important. But doing something about it for her meant that she's probably going to, the next phase of her life is going to be a lot healthier than what it would have been.
Absolutely.
So we might move on now to the next section, which is Annabelle's going to talk about lifestyle and the prescription of GLP-1 medications, because they're certainly increasing in favour and popularity. So I'll hand over to Annabelle now.
So the GLP-1s have been an exciting addition to our glucose lowering toolbox. We know that a GLP-1 is a naturally occurring hormone in our gut, but it is blunted in people that have type 2 diabetes. Now, we really are encouraging the use of GLP-1s in our patients with type 2 diabetes, because we know that the medication will stimulate the release of insulin by working on the pancreas, therefore lowering a person's blood glucose levels. We know that they reduce the release of glucose out of the liver, again, reducing a person's blood glucose levels. These drugs slow the gastric emptying, and they reduce those post-meal glucose spikes. The GLP-1s work on the appetite center in the brain, which help to promote weight loss. So this is really an added benefit. They reduce hunger and they increase satiety. I'm often asked, how soon will a person get that suppression of appetite? And I find that it normally occurs within days of the person having their first injection. Because their appetite is suppressed, they've got reduced food intake. They really just don't feel like eating. They're not watching their clock and going, oh, it's 8 o'clock, I have to eat breakfast. It's 12 o'clock, I have to eat lunch. They're just not getting that feeling that they want to eat. I tell my patients, don't eat unless you're feeling hungry, because and don't overeat. So I think we've all been, majority of us have been brought up to eat what is on our plate. I encourage my patients to serve out a smaller meal, to eat it slowly, and if they feel they need more, then go back and get some additional food, but basically eat a smaller meal, and they will find that they really don't need to go back because they're getting that appetite suppressing effect. Recent studies have shown that the GLP-1 has some cardiovascular benefits. So it will actually reduce the systolic blood pressure, reduce the diastolic blood pressure, reduce inflammation, and reduce dyslipidemia. So currently in Australia, we have a range of GLP-1s available. The first GLP-1 became available in about 2005, and that was actually a daily injection. That particular one that I'm thinking of is no longer available on the Australian market. And we do have one daily injection available still, liraglutide, and that is either Victoza or Saxenda. Now, Victoza we do not see very often now, and I believe it is in limited supply, and the manufacturers are encouraging us as clinicians not to start any new patients on Victoza. If you've got patients already on it, certainly continue to use it, but don't start any new people on it. And I am still seeing people start Saxenda, which is a daily injection. And the person that I would start on Saxenda is that person who is really apprehensive about starting a weekly injection because of the nausea. So sometimes it might be wise to start your patient on Saxenda just until you see whether they're going to develop nausea, because it will be out of their system sort of in a couple of days, and they don't have to put up with the nausea for a week. The most common GLP-1 that we're using at the moment is Ozempic. Now, Ozempic is PBS listed for type 2 diabetes, for diabetes management. And we have two different strengths in Australia, two different pens. One is the 0.25 / 0.5, and then we have the 1 milligram. Of course, there's been some issues around supply, and that I find that it seems to be an area-based thing. Some areas don't seem to have any issues and others do, but it is the only one that is PBS listed for diabetes management. Wegovy is available on the Australian market. It was launched in August 2024, and it's not PBS listed. It has been launched for weight management. Recent studies with Wegovy have shown some very positive outcomes, particularly in relation to reduction of waist circumference, reduction in HbA1c, cholesterol, systolic and diastolic blood pressure, and also an increase in around physical activity. So it allows the person to increase their activity. Duraglutide, Trulicity, is still available on the Australian market. It's a once weekly injection, and also it is PBS listed for the management of type 2 diabetes. Tirzepatide is probably the newest GLP-1 on the market, and the brand name for that is Mounjaro. It's a weekly injection, and it's approved for weight loss in Australia. It is not PBS listed, but I know that hopefully it is going to be in the future. So the benefit of combining a GLP-1 medication with lifestyle intervention is that it supports healthy weight changes. Often our patients, they feel, as Angela said, they are eating in a healthy way, and we're encouraging them to eat in a healthier way. Sometimes their diet just needs tweaking. But with adding in the GLP-1, they often will see a more substantial weight loss, which is actually really a motivator to them. So if a person makes changes to their diet, but they don't see a weight loss, it can be really discouraging. And they think, well, why am I giving up all those things that I really like when it's not doing anything? But by adding in that GLP-1, they see the weight gain, they see the reduction in their waist circumference, they see the reduction in their blood pressure, and that is a real motivator to them. We know that by improving their weight, they're going to get an improvement in their diabetes-related and health outcomes. And it can also reduce their medication dependency for long-term management. So when we start a person on a GLP-1, if they are already on insulin, we will normally reduce that insulin. And in fact, we often can get rid of, if they're on a long-acting insulin, a basal insulin, and a bolus or mealtime insulin, we can often get rid of that mealtime insulin, which is wonderful for the person. They may just have to have a small dose of long-acting insulin and then the weekly injection of the GLP-1. And that really reduces the burden for the patient. And another aspect to consider is the financial impact that having all these injections has on the person. So you're reducing that financial burden as well.
Case study time. Yay. Sorry, I was typing some answers. And just a quick case study because we're chugging along with time. Quickly, Massimo's 68, BMI 29, diagnosed with type 2 diabetes 5 years ago, HbA1c 8.3, lives with his partner and still works part-time. He's attended the local diabetes education class when he was first diagnosed, and he's currently on metformin and a SGLT2, which he's not happy about because it's actually caused him some side effects, urinary tract infections. Intervention, review of the medication due to the side effects, and as part of the annual cycle of care screening happened, and the decision was made to change his medication as a result. And his wife's very supportive around all of this. Again, it's around nutrition and physical activity plan and referral to the Get Healthy service. And the good news is, after all that, 6 months on, he's got an improved HbA1c. It's still not in target. However, he's got a 10% weight loss, so he's doing really well. And again, that's probably the GLP-1, as well as he's increased his physical activity levels, because he's mindful with his age that he doesn't want to lose muscle mass because he doesn't want to have some falls. And he's been attending an exercise program for the last 8 weeks. He's managing the weekly injections without side effects, which is also good news. So Annabelle, next slide. Just quickly, why an GLP-1 rather than a different type of medication? Because there's quite a number of different classifications of diabetes medication at the moment.
So I would consider commencing Massimo on the GLP-1 because his HbA1c was elevated. So therefore he was at increased risk of developing diabetes-related complications, retinopathy, neuropathy, nephropathy. And we, that is our goal, is to avoid those complications. Now, this gentleman, he wasn't doing much exercise. He hadn't attended a dietitian for a while. His wife felt that she was doing everything right, but he found that when he attended the program, he actually gained a lot of knowledge, both he and his wife. But then we started him on the GLP-1 because he was getting side effects from the SGLT2. Now, remember, the main side effects from the SGLT2 are UTI, thrush, and for a man, balanitis. And it's important also, we're talking about GLP-1s tonight, but it's important when you talk to your patient on an SGLT2 that you do mention those side effects to your male patients, and of course the UTI and the thrush to your female patients, because they really do suffer, and they often they don't relate the two. So he was getting side effects. We started him on the GLP-1. His HbA1 dropped down. It's still not where we really want it to be, less than 7, but it is okay. The weight loss was good. Now, the one thing I would really, really encourage here with this patient is that you advise him about increasing his intake of water, increasing his intake of fibre. Very, very important when we're putting a patient on a GLP-1, and also making sure that they are doing some resistance exercise. So encouraging them to use TheraBands, use light weights, very, very important, so we avoid that muscle mass, because if they think they're getting muscle wastage, they're not going to want to take the medication, but we can overcome that. I would also look at Massimo's sleep habits. Like, is he sleeping well? How many times at night is he waking up? I would ask him about his intake of alcohol, and just ensure that he's not drinking too much, that he is having a couple of, if he does drink, make sure he's having a couple of drink-free nights a week. Make sure he's not drinking too much soft drink, flavoured milks, orange juices, encourage him to be drinking the water. Ensure that he's having his eyes, feet, kidneys, hearing, teeth, and a sleep study if necessary, checked every annual, as per the recommendations in the annual cycle of care. I would be ensuring that he is being referred, to have his eyes checked, his feet checked, his those things that are mentioned in the annual cycle of care.
Great. I think what we might do is just go to the next slide, rather than, I think what Annabelle's given is a very complex and complete answer to that. So I think we might move on to the next slide. Annabelle? So
this slide, while it's quite small here, even for me, it just shows how you can prescribe these medications. So a GLP-1 can only be commenced in a patient with type 2 diabetes if they have had an inadequate response to an SGLT2. Now, if you start a person on a GLP-1, you should really stop the SGLT2 unless they are taking it for a cardiac or a renal condition. If you feel that you want to continue the SGLT2, you could prescribe it on a private prescription. The person starting on the SGLT2 also has to have an HbA1c greater than 7, or they have to have shown that they have they've been blood testing, and 20% of those blood tests over a certain period of time are greater than 20%, greater than 10%. So it's important that you look at those guidelines. So they don't have to be on, you know, a sulfonylurea and a metformin, but they do have to have been on SGLT2. Angela, I'd just like to also mention here that if the patient is taking a DPP4 and you start them on an SGLT2, both are in the incretin pathway, both the DPP4 and the GLP-1. So the DPP4 should be stopped because it's of no benefit. Also, I wanted to mention, because we are running out of time, that if you're considering starting a GLP-1 in a person that has a high HbA1c and they've had diabetes for a long period of time, there's probably nothing left in their pancreas. They really don't have additional insulin there to do anything. So really those people need to be started on insulin therapy. Don't delay, start them on insulin therapy. The DPP4, the GLP-1s, they all work better early on in the disease process, not when the person's had diabetes for 20 odd years. So, you know, be really proactive and get these people on these drugs. The GLP-1s can cause some nausea early on, but they normally, you know, after 1 or 2 injections, those side effects normally settle down. So the common challenge is that they have a risk of reduced appetite. Really, that's what these drugs are doing. They're reducing the amount that a person's eating. The main side effects we see are nausea. Now, it can be just a couple of days or it can be for the first couple of injections. If the person is having, you know, they're really feeling unwell, but they want to persevere, you could prescribe them on Danzatron. I wouldn't suggest you prescribe them Maxolon or Stemetil, because that drug actually speeds up the gastric emptying and the GLP-1 slows the gastric emptying. So you've got 2 opposing teams there. Try and set some goals with your patients about what you expect. You know, you don't expect them to lose 20 kilos straight off. Just do those SMART goals. The costs sometimes can be a challenge. They are expensive. Of course, the Ozempic is on the PBS, but the other weight management drugs are not, and they are quite expensive. So when you're starting a person on these drugs, you need to indicate to them that really they are a long-term drug. If they went on to insulin, they'd know it was long-term. These drugs are also long-term. They're not just for a month or 2. Sometimes there's some fear around giving injections. That was where I would really encourage you to refer these patients to a credentialed diabetes educator, where we can really help the patient get over that fear. It's a very, very easy process and a very, very small needle. As I've already mentioned about the muscle mass, we really encourage that weight resistance. In fact, we think that the drug should actually come wrapped in a TheraBand so that the patient will start doing some resistance exercise straight away. Next slide. All right, so if the GLP-1 is stopped, the person will normally experience a change in their appetite. They'll have increased hunger. And this is where the weight gain comes back in. So there's great potential to regain not all of the weight they've lost, but certainly I think on Ozempic they say they'll regain about 13%, 13 to 14% of the weight that they lost. there will be some, usually some emotional distress around that weight gain. So we need to, discuss that with the patient. Their blood glucose levels may increase, and they have increased cardiometabolic risk factors due to an increase of their blood pressure and their lipids. If you have stopped some of the medication with a person who starts a GLP-1, please consider restarting it again because that will keep their blood glucose levels down. They may be concerned about how long they've got to take the therapy. They need to maintain the lifestyle changes that they implemented, that they learned in some of the programs that Angela's mentioned. And emphasize that the lifestyle interventions are very important. They need to continue on with those, monitor their weight and their glucose levels, and look at those, their HbA1c, fructosamine, and their biochemistries.
Okay, back to me, and we're going to go really fast because we're going to answer a couple of questions. So next slide. You will be getting these slides in the pack, so I'm going to just go to the ones that talk about the Get Healthy service, and which I think is really important. So if you just go to the next one, this one. Can you go back just one click? Thanks. The Get Healthy service has been around since 2009. It's a great program. Diabetes Australia, that's where I work, is currently delivering the Get Healthy service for New South Wales Health. And I think the program itself is of value to you as a general practitioner because it's a program that you can actually refer anyone over the age of 18 to the service so that they can actually work out their health goals with a health coach, and we can support them to actually achieve those goals to improve their health. Now, they can be living with diabetes, they can be living with hypertension, cholesterol, they can just want to become they're just wanting to become healthier. There's many reasons why they can be referred to us, including, as I said, the people with diabetes. It's a program that once you refer the person to us, they can also refer themselves as well if you give them the information. Either way, it's really easy to be referred. The benefit is it's free. They get 10 coaching sessions, and then they graduate. If they still haven't quite achieved their goals, or they want to start with some new goals, they can re-enroll and then the whole process starts again. So it's not just a one-off, here we do it, it's an ongoing if they choose to have it ongoing. The good thing about it is they get to choose their coach, they get to choose the time they want to have those phone calls or video calls. We have supportive information, they get access to resources, webinars, Q&A sessions. So there's lots of support around that program as well as the coaching calls. So it's a really great program that can support you in general practice as a free service that people can actually access. So if you go ahead to a couple of slides, please, Jasmine. I will mention that you do get a lot of correspondence once you refer someone. We send you communication along the way on the person's progress if you choose to receive that, and you get a progress report at the end once they've graduated. So there's a bunch of ways that you can refer people. The best is if you're using Medical Director or Best Practice, it's actually inbuilt into the program. Just go to Specialist Referrals. You can actually auto fill in the referral and send it to us and we'll do the rest. There's Website Referral, and you can just click on that button and enter the details and go through it. Oh, can you just go back one, please? You can email in a referral, you can print off, there's actually a paper, no, it's online, but you can print it off and fax it if you'd like to, or you can email it through, or the person can self-refer, which I think is a lovely way to do it if they want to, on the website, or they can ring us on the phone number 1300 806 258, and they can we'll do it all over the phone for them. Not everyone likes to use technology to do their referrals. So if you've got a minute, remember, you're getting this presentation, so I would ask you to go through those slides about the Get Healthy service if you want to know a little bit more about it. But what you do need to know is it's a great service that can support you in getting the patients that you see started on their health journey. So thank you.